The average 80-year-old who's got high blood pressure and, is golfing and doing whatever, they don't need a geriatrician. They have a good internist, a primary care provider, family medicine doc can take care of, I would say, 80 to 90% of the geriatric population. The 10 to 20% who should come to us are those with many medical problems, many medications, stresses. They can be psychological, cognitive, mood. And when you start having so many things, it just takes time. And often even a good internist or family medicine primary provider doesn't have the time or the resources. So it's not that I'm necessarily smarter. I'm more trained in some of these nuances, but I also have more time, and I also have a staff who's well trained and knows all the resources. So we do better at the tip of the iceberg of the patients who are the most complicated, the most in need, who can overwhelm a primary care provider's practice. We're positioned. That's what we do. So we want them. We're happy to see a robust 90-year-old, but we're really better off seeing the people who need the extra TLC. There's two main things. One is focusing on function. What really we all want to do as we age is maintain our independence and ability to do the things we both want and need to do. So the goal of care isn't necessarily to bring your blood pressure down 10 points. It's to bring your blood pressure down so your kidneys, your brain, and your heart are happy, so you maintain your function. And we kind of always I keep that functional endpoint, not a number, not a lab test, but how are you feeling? What is going on in terms of your functional abilities day in, day out, whether it's aches and pains or whether it's cardiopulmonary problems, to keep those things from not slowing you down, or at least still allowing you to do the things you want to do. The other point that I really focus on is communication, and all providers do that, but I think in geriatrics it becomes even more important because there are often difficult choices. There's multiple problems that perhaps might need to be dealt with medically. There are care treatment choices, and one really needs to sit down and communicate. Here's your situation. Here are some of the choices and options available. And then really take the time to understand why the specific patient in front of you might choose or not choose to pursue various diagnostic tests, various treatment options. It really needs to be focused on the individual. And again, all providers do this, but I think we have a little bit of additional training. And I personally know it's one of my focuses to have the time and energy to really sit down with the patient and sort out what makes sense for them. There's a study done of who's the happiest doctors in the medicine subspecialties, and it's geriatrics, hands down. It's been every 10 years they do this survey, and we're the happiest. We have the best patients, the best stories, the best rewarding interactions. And I went into it because I like talking to older people. It started with my grandparents, and it continues with my adopted grandparents.